So now we're going to take our first session into a very crucial field of healthcare, an area where behavioral science has been applied in some really interesting ways. And we're pleased to welcome, to the first time for the Human Advantage, Ismaël EMELIEN. He's the founder and CEO of a healthcare startup called ZOＩ that we're going to learn about. And he's going to share with us both his company's mission and how behavioral science contributes to not just the mission, but also the operation of the business. So Eric will conduct this interview. So Eric, over to you.
Bonjour Ismaël, ravi de t'avoir avec nous aujourd'hui.
Pour cette invitation.
Alors, juste un petit mot pour mon ami Ted qui souvent se moque de mon accent pourtant parfaitement anglais. Sa prononciation de ZOI en Zoé était assez mignonne. Donc effectivement, Ismaël a créé une start-up, on va y revenir, spécialisée en médecine préventive avec son associé Paul. Et puis, ce que j'aimerais d'abord, avant qu'on parle de sciences comportementales, c'est vraiment essayer de comprendre la genèse de ZOI et d'abord, quelle idée t'a amené à créer cette start-up.
C'est le résultat d'une rencontre assez aléatoire et improbable. J'ai rencontré un médecin qui s'appelle le docteur Claude Dalle, qui, pour des raisons qui lui sont personnelles, a développé au fur et à mesure de sa carrière de médecin une approche très innovante de la médecine préventive, une approche qui est à la fois ancrée dans la science et que la frontière technologique de la science et la communauté scientifique et médicale met en évidence année après année, et qui prend en considération toutes les barrières comportementales que nous sommes tous porteurs et tributaires pour essayer de réduire en permanence ce petit écart entre la personne qu'on aimerait être et puis celle qu'on est vraiment, parce qu'en matière de santé, à fortiori préventive, c'est l'accumulation de comportements année après année qui crée les risques ou les opportunités.
Et en fait, c'est même une expérience personnelle qui t'a amené à te dire, tiens, l'idée
J'ai
rencontré ce médecin au départ pour discuter.
So I met him initially because I was interested in his work, and he offered me to become part of his protocol. And this was the first time I was subjected to a range of tests. It was pretty chaotic. We were sent from one place to another, one specialist to another. It went on and on and on. This was during COVID-19, which added more complexity, as if it weren't complex enough already. And for the first time, within 1 hour, I had a physician who gave me a very comprehensive, consistent picture of everything. My pathologies, some of my problems that I thought were completely disconnected from one another, which was not the case, and gave me an overall protocol on how to address them. I followed the protocol. Of course, there is the placebo effect, and I always, I'm cautious about myself. I was reassured about the scientific context and the fact that everything is measured. The same analyses are done a year after, and you can see that things that were not looking good or have been addressed, corrected. I had digestive problems, which I was unaware of for various reasons, not very serious reasons when you look at them individually, but put all together, it can be a problem. My immune system was quite weak. And this had actually been the case since I was a kid. And typically, when you reach the age of 50 or 60, you become a lot more vulnerable to viruses like the flu, for example. And the flu is still killing a lot of people today. Thousands of people die every year because those people go unprotected. It's not so much because viruses some year can be stronger. Generally, it comes comes from the fact that people have a weak or low immune system, which was my case. My immune system just was not very good. Interesting. So your system is about identifying potential risks to actually treat them, address them, to make your life a better life. Exactly. We all know we should not eat junk food, fat food, sleep well, don't smoke, and so on and so on. But we still don't know what all the other risks we're exposed to are individually. And nobody really gets it right. It's very difficult to identify what risks you're exposed to. A lot of people think, well, I think I eat okay, I don't sleep very well, but I work out, and then based on all that, you decide what to do. Focus more on such a thing. So anyway, with ZOＩ, ZOI gives you a full health map. With ZOＩ, you know precisely where you stand. It's based a lot on your history, on your health track record since you were young, and it gives you perspectives as you move forward. It's very personalized, very customized. It's not something based on very generic statements saying, yeah, if you exercise, exercising is healthy. It's a bit easy, you know. If it were that easy, everybody would just exercise and feel better. We try to take a much more detailed approach, and we also ZOI also helps you explicit what to do, what steps to take to make your life better. It's a subscription. It's subscription based. We would like to open it up now to more people. And really go from prevention to prediction.
Merci.
Okay, interesting. We'll come back to that notion a bit later. Before we move on to behavioral sciences, some know or may not know that you were involved in politics. You supported Emmanuel Macron since 2014. You managed his 2017 campaign. You were a special advisor at l'Élysée. What happened? Why did you move from being in politics to creating a startup company? Well, I think it is simply something I wanted to do. I met a number of people during my career, and my impression is that politics require a lot of commitment, but you cannot. I see politics as a mission, as an assignment you complete, but not as a profession. So it lasts for a limited period of time. So during that period of time, you can do a lot of wonderful things, which is what I did. But you're not stuck. I didn't want to be stuck in politics. Being in politics is not like being in real life. And I decided time had come for me to go back to real life. So this is really my personal interpretation of politics and how I see politics. Okay, interesting. I think we now understand the concept of ZOI and your mission, the mission for ZOI. Could you now tell us a bit more about behavioral sciences? I remember we met for the first time in 2014, and back then you said, don't tell me about nudge, I know nudge. But you had a question. The question is, how do you apply nudges? So since then you discovered behavioral sciences? Yes, I actually discovered behavioral science before you told me about it. I've always, again, this was when I was a politician, I was very interested in behavioral sciences and in politics. And I also followed Obama's campaign, and a lot was done during Obama's campaign quite successfully to include in Obama's campaign the notion of behavioral sciences and how to manage biases and to understand why a message is perceived or not perceived, seen as credible or not, rejected. It depends on a lot of things. It depends on a political context in a given point in time. It also depends on behavioral variants or variables. This is very true in the US, very true in France, and anywhere else. And we discovered the power of this and the benefits of this during Obama's campaign. I looked at how he implemented. Obama implemented things when he was elected as in office. Back then, I didn't understand why I was one of the only ones. Nobody really seemed to pay much attention to behavioral science. I was interested back then in public finance, the excessive debt of most developed countries, and having an approach which works, very results-oriented, in my mind was very attractive, very interesting. And it also allows you to sort of bridge the gap between politics and people. And I felt it was necessary to actually bridge that gap. People have to relate. People have to see how political decisions, influence their lives, their real lives, or not. How you can give credit. There is a lot of uncertainty. And oftentimes, political decisions either don't happen, or when they're made, they never really make an impact, or people don't really realize they make an impact. And therefore don't recognize they make an impact. So behavioral sciences there can make a big difference. Okay, very good. So let's go one step further now, Césaric, and
l'intérêt pour toi des sciences comportementales avant de rentrer dans leur application concrète dans ZOI.
Before we look at ZOI and how behavioral sciences work with ZOI, tell us about behavioral sciences in healthcare first. For you, it really makes sense. Yes. Again, think about the gap between who you are and who you want to be. This is where the consequences are the biggest, individual consequences, because you're exposed to all kinds of challenges and difficulties that could have been avoided. It depends on our family. In some families, you have certain pathologies. When you have a pathology in your family, it impacts all the other people. It's true socially, it's true collectively. Our healthcare systems are fragile. And quite obviously, when you think about public health, obviously prevention should play a more important role. And when you think about prevention, the first thing that comes to mind is taking action. And then changing your behavior. If you change your behavior, you can change the outcome. So behavioral sciences are absolutely central, absolutely key to make our mission, which is a mission of general interest, successful. Okay, one step further. Yeah. Let's talk about ZOI. I know ZOI quite a bit.
D'abord peut-être, et moi c'est ce qui m'a le plus frappé, dans la recherche d'expériences exceptionnelles pour le membre dans la collecte de données initiale, avant de parler de ce qui est fait dans l'application,
data collection. Before we actually talk about the application, before we talk about recommendations and how.
Et même, on pourrait dire en amont, quand vous avez créé et
when you create ZOI, you can develop this.
C'est-à-dire là où se passe la collecte, le diagnostic.
You developed an office, Centre Vendôme, where you collect all the data, but you did a lot of nudging and behavioral sciences with your suppliers.
Un exploit en termes de timing et de qualité
in terms of timing and quality.
Qu'est-ce que tu pourrais nous raconter
your achievements were outstanding. So could you tell this, the ZOI, the journey of joy, of ZOI, and if I'm a member, how does it work? You become a member for 1 year. You take take a 1-year subscription. You go to a healthcare center. We have a healthcare center. It's near Paris. It's a 3-4 hour health checkup. So again, this is something which has been very much developed with behavioral sciences in mind. A few weeks after, you get a feedback session by a medical doctor, and how all this translates into recommendations. So regardless of whether you're a man or woman, it gives you an overview of everything. How are you doing in terms of pathologies, digestive pathologies, and so on. How your metabolism is doing, and what you should quit, what you should do differently, what you should start doing to increase your chances, to postpone a potential risk. We may discuss this later in the conference, but 75% of non-transmissible diseases, pathologies, the ones that kill people, are avoidable. 75% of them can be totally avoided. Cancers, most metabolic diseases, type 2 diabetes, cardiovascular diseases, and you can't fix it all when you're 78 years old by changing one little thing. But if you make small changes early enough, and if you act preventively, you can change outcomes. So this feedback appointment with a physician defines what you're going to do, and the rest of the year is really on the app, based on behavioral sciences, to make sure that the recommendations that are sent are communicated at the right time, the right way, in a very obvious and clear way, easy to understand. So for the first time, it's not just recommendations that people don't listen to, but it's recommendations that people will pick up on and apply. And just to add one more thing, we had to find a location to do the health checkups. Well, hold on, let me interrupt. You said in your personal experience you had to go to all kinds of places when you had health issues. Yes. In the field of prevention, you are the solution. So it's not about getting a health checkup. It's about having an impactful health checkup, a health checkup that is going to change your life. So we were able to find great talents at ZOＩ to make this happen. So we had to create this experience, both physical and digital experience. And at any time, people should have a pleasant journey, which is not easy when you're dealing with healthcare. We have our public hospital system, and I'm not talking about the luxury hospitals, but I'm talking about the length of interaction with with healthcare professionals. I remember talking to a nurse who had been practicing for 30 years in a hospital, and she told me, this is the first time ever I have spent 2 hours with a patient. She had never done this before. Here you have someone who's with you, for you, uninterrupted for 2 hours. So this is part of the experience. It should be, ZOI should be a positive experience to create the right conditions so people can understand and then take action. So we need a physical location, a place, different from anything we know. It's not a hospital, it's not a clinic. We really started from scratch. So we created this new location, this new venue, which has everything it takes to conduct medical tests. I'll give you one example in how it's different. When you do a health checkup, you have to go from one office or from one venue or one location to the next. You see a specialist, you see another specialist, then you need specific equipment, so you need to go somewhere else. Here, everything is in one location. So instead of you going to different locations, the different locations come to you, and you have your room, and people are there for you for 2.5 hours. No waiting time. No need to repeat the same information to different healthcare practitioners. Everybody has the same information on you. And once again, during this journey, when you meet, so when you enter the venue, the door opens and you're in a place which is fairly dark. With very good sound, it's soundproof, and to really show there's a transition between the outside and once you're inside. When you're inside, people are there for you. When you walk inside, you can leave all your trouble, all your problems, all your concerns behind. And very basic exams, like an ECG, for example. ECG is very, very basic. When a doctor says, relax, what do? You do the opposite. When a doctor says, relax and breathe, naturally you get stressed. When you have electrodes all over your body, it becomes stressful. So we developed a medical device to actually apply electrodes and remove electrodes. And we used we dim the lights based on breathing patterns. Patients, and we don't tell patients. So you're the patient, you're on your back, you're watching the ceiling, and when you breathe, the light dims and synchronizes with your breathing.
Et ça a deux effets également importants pour nous. Côté patient, ça rend le moment.
For the patient, it makes it a more pleasant experience. Some people actually fall asleep. We've had several patients who literally fell asleep. And the other benefit is that it allows you to collect very high quality data. We can standardize this data, and this makes our diagnosis more reliable. So a quite exceptional experience with Kahneman's work or the East brothers' work. We know that what's the heart of this, what's important here is something exceptional. Not something good, something exceptional. These peaks of exceptional moments. Could you develop that notion a little bit? Yes, I discovered this quite a while ago. The problem is we can't always control peaks, but the problem is that when you have a peak, you have a trough. So we try to create the right conditions to have a lot of positive peak opportunities. I mentioned just a couple before, but some people may not like blood tests. We do everything possible to make blood tests a pleasant moment. But the problem is that people still consider the peak to be a negative peak because of the injection of the needle.
Ceux qui nous écoutent le savent, le deuxième moment qui est le plus retenu en moyenne, pour le coup, soit de manière univoque, exceptionnelle, et donc on a rajouté un espace de balnéothérapie médicale qui est accessible sur ordonnance, évidemment, et qui est le reflet
additional services.
Donc chaque parcours est adapté à chaque individu.
So people have
pas besoin d'aller en thalassothérapie, c'est aucun
a process, an experience which is really adapted to their profile. I actually visited ZOＩ, and after the checkup,
parcourir ce Hansen avec un parcours personnalisé.
Donc ça, je veux dire, c'est l'expérience première with the possibility to have a bath
bascule sur la restitution des résultats. Est-ce que tu peux nous dire un peu comment aussi tu essayes d'utiliser les sciences comportementales, ces gens structurels dans la partie de la conception d'immeubles et dans la restitution?
On essaie de faire se rencontrer le raisonnement du médecin avec la perception du patient.
What's important is how doctors think and patient perception. So we try to get rid of silos. Most physicians, specialists don't communicate, don't interact. So when you get a standard, when you do a normal checkup, you get the report with all kinds of numbers and long columns. So we collected that data and we try to make it more explicit, easier to understand and digest for patients.
Et donc, de la même manière que
it's a bit like a guide that describes your body.
A bit
like when you buy a microwave oven.
C'est pareil. Donc, tu vois,
the instructions that come with it are not super detailed, technically speaking, but the guide presents the main functions of the microwave oven. It's exactly the same thing here for your body. All body functions are presented in a very explicit way. So the feedback session is conducted by a physician, correct? Yes, by a medical doctor. And we didn't want this to be standard with a table, the doctor on one side, patient on the other side, or sometimes a screen, the computer screen in between, where the physician is watching the screen but not the patient. So we try to find the right angle. The two are actually sitting almost side by side, and they're both facing the screen. And the physician will then read from the screen and explain what the results are. And what the diagnostic presents and what the conclusions are.
Si je continue le parcours du membre,
so let's continue. As a member, as a ZOI member, subscriber, you have an app. There again, you used behavioral sciences to develop the app. And the biggest challenge is at the end of the day, do members, do subscribers pick up on those behaviors, and do they actually apply them? Good question. We don't believe in long lists of recommendations that people never follow because they're not delivered properly, for example. The ZOI app will sync with your professional life or personal life. So it will give you information not when you're having a meal or in the middle of a very important meeting at work. And so that's one thing. In order for patients to really stick to the recommendations in the long run, we created a digital system which makes sure that you take your medication or supplements at the right time of the day, day after day. Okay, I think I now have a better understanding of how you used behavioral sciences for your patients, members, subscribers, in a meaningful way.
L'aventure ZOI, j'ai envie de dire,
what I found interesting in ZOI is the use of behavioral sciences for patients, but how it really has shaped the company's culture, ZOI's culture. Could you tell us a bit about that? Yes, I think that's even more challenging.
C'est quelque chose qui du coup est en amélioration.
And this is really an aspect we keep seeking to improve. First of all,
et faire mesurer l'intérêt des sciences comportementales à l'ensemble des
we had to convince all team members about the importance of behavioral sciences. Some of the people working with us were very disconnected from behavioral sciences. Some people do research, we have scientists, we have real estate experts, we have support functions. So all these teams work together, but we had to explain to them what behavioral sciences are about. and what the benefits of behavioral sciences are, how they work, and so on. So to make people realize and maybe realize that they could also use behavioral sciences. Second, within the organization, we need to find the right moments, the right opportunities to leverage them.
Soit une intervention, soit un exercice qui est tiré directement des sciences comportementales.
And it's largely inspired by, once again, behavioral sciences.
T'essayes d'organiser des
So
événements
you
qui sont incroyables et qui sont aussi pour les collaborateurs très
for employees
mémorables.
and that are very memorable for them.
L'expérience qu'on est en train de créer pour nos membres,
Yes.
Elle a un parallèle qui est que, évidemment, si l'expérience de travail permet elle aussi.
We think it is important to provide our customers, our members, with a great experience. Likewise, we think it is important to provide an equally exciting experience for employees. Ismaël, as you may have noticed, the clock is ticking. I know, I'm very talkative.
De l'avenir.
That's not what I meant. Let's talk about the future. You have a very clear picture of ZOＩ moving forward. You briefly touched upon the future. Could you tell us how you see ZOI in the future? What is your vision of ZOI?
Au maximum de gens.
And how do you intend to give access to ZOI to as many people as possible? Well, we now have this checkup. The checkup in total includes checks. It covers 20 different areas, 200 biomarkers. There's no limit. Anything that should be collected is collected.
Négocier des tarifs de groupe, bref, pour rendre ça le plus accessible possible.
We're trying to make all this quite affordable. It's expensive. The subscription costs €3,000. But if you had to do all the health checks separately, it would probably be a lot more expensive, but I recognize it is expensive, so we want to make it more widespread. We do not want to compromise on quality. We do not want to have, lower quality health checkup, because that would lower the quality of the outcome of the results. So since day one, we have been working, we have a mission, our purpose. This is in our legal statutes. So this is something we have not just said, but actually done very operationally. It's been audited, it's been certified. We have this purpose, and our objective now is to lower the cost of the service, so we can provide it and offer it to as many people as possible, but at a much lower cost. It's very difficult at this point to give you a date. We're not talking about 20 years from now.
Généralement assez concret dans tes ambitions.
Okay.
J'ai une deuxième question.
I have a second question.
Et sortir de ZOI, ça sera mon avant-dernière question.
It's actually my penultimate question.
Est-ce que tu as un point de vue sur les conditions de succès de la médecine préventive?
What does it take to make preventive medicine really successful?
So I think you need to be very much connected with your target. What I mean by that is there is a trend in the US to extend lifespan. People who are born today, it's expected, should be generally hitting 100. And what we've seen, like anybody else, is that it's not so much about living longer, but living longer in good health. The life expectancy in France to live a healthy life is 63, really. So most of the additional life expectancy since the Second World War is really in bad health. So that's what we want to try and address. You're not adding years on your life expectancy per se, but to have additional years where you're going to be able to enjoy them. So that's the first fight, if you like. It's not the magic wand that is going to reverse aging. No, it's trying to make sure basically that we can live to our last dying day in good health. of course, this requires a sea change culturally, right across the spectrum, from training medical personnel all the way through to technical investment, and also how you're going to do things, applying the approach, for example. And so, of course, behavioral science is front and center in all this because, it's really the alpha and omega. And I suppose, thinking about my own experience, this is where the last mile really is where it all matters. You can have the best diagnosis, the best recommendation, what have you, but of course, if you don't get ultimately to the end of the finishing tape, it's all a waste of time. So we need to take into consideration why we don't behave to the benefit of our health. It's not talking about too much drinking or whatever, but it's a whole collection of behaviors that ultimately will be a disservice to your healthy, long life. Farida Messouni, I point out, from the WHO, will be showing later on how we can use behavioral sciences to make sure that women track the potential beginnings of uterus cancer. We'll have a roundtable as well with big pharmaceutical experts who will be offering us insight to use behavioral health, behavioral science rather, for better health. My last question, you've got with your hat on as a startup founder, what advice would you give to somebody who's just created or maybe thinking about creating a startup, thinking about trying to factor in or bake in behavioral science? What should their starting point be? Well, I think reading, really. The literature is not voluminous. One or two books would help ready the way or lay some sort of groundwork. And then seeing, hooking up what they read in the book to some sort of practical hands-on approach for the building of their company. Cadman, for example. It's a solid writer. Some of these are the founders of this discipline. Singler is another major name in the field. So I think you need to read about 6 or so books and then try things out. Really, that's the approach I would suggest. I mean, it's a very applicable science. That's what's good about it. You just have to try it out. There's an opportunity. There might be a stumbling block, and you think, oh goodness, I don't know why this isn't working. It looks like anybody would show buy-in, but it doesn't need to be working. So what's this gap? How can I shore up this gap, and how do I make sure that I can get the tipping point? Brilliant. All right then. So I was very kindly given a tablet where there are 1 or 2 questions from the public, from our audience here. So here's one. I've got a number in actual fact, but I'm trying to make a selection because we've only got 3 minutes 46 seconds if I've read the time properly. So here's one. This is about how you can think about testing effects that may actually arise 30 years down the road. Through your company, of course, you want to add on years of life, but unfortunately, you can't really tell. Well, yes, before you have a stroke, there's been lots of negative, measurable staging posts, if you will. So that will help you. If you address those, you can short-circuit the stroke. I mean, obviously, we can't have evidence to suggest the contrary. I mean, I don't know. Let's take diabetes, for example. Sugar in the blood obviously will augment, and eventually you will get diabetes. And if you can interrupt that, then somebody who would have got type 2 diabetes, well, he won't get that pathology. Obviously, you can't know what's happening until you reach the end. There's a doctor, for example, who spent used an evidence-based approach over a 30-year period, and he moved from then actually to information-based approach. So you're converging information in order to be able to gauge an ultimate effect and avoiding, of course, the pathology, or at least the risk that will accumulate to actually produce a nefarious pathology. Another question from a behavioral science specialist. I'm translating into French, says the speaker. So, you've got this feedback loop through your members, through your patients. But why is that loop different to what you may hear from other advisors, carer advisors? Well, I think the difference lies in this. The spectrum of what we're covering medically in the checkup, which should be able to hook up any data that we'll collate afterwards through the healthcare or dietary experts. And so it's much more of a granular and effectively meshed approach. If you eat a huge amount across the day, that's different to eating in one massive meal. So, or even exercise. It's best to do 3,000 paces rather than 5,000, depending on whether you're sedentary or not during your working day. So there's a granularity dimension that can be tailored to the individual, and that therefore you can hook up every detail of somebody's life. And of course, physical activities linked in pollution, quality of sleep, and basic exercise. All right, next question, the future then of the company. I heard about expansion, is that right? Yes, we want to extend and continue to extend the number of members that we can offer a service to in France. You've got past the 1,000 threshold, haven't you? That's right. And then opening up things internationally, that'll be the next stage. Lovely, great. Well, listen, I mean, this is fabulous, and I'm a bit biased because I was very much involved personally in this conversation. Anyway, but thanks very much for the teams who are making this event possible. And thanks very much for the listening public.
So much for that session, Ismaël.
Brilliant. Thank you very much, Ismaël, for that sequence. The foundation of ZOИ is this core.
Just isn't enough. So all that health information that you're capturing, but we still need to use behavioral science to motivate those better health behaviors, and we're excited in our very small part to be a part of that journey with ZOI. Before we break for lunch, I want to check in with Adrien. Adrien, where are we at? Day one, first half is done. What do we have?
Maybe we can go back to a previous session. That one about food, I think, was really interesting. Yeah, that one was really interesting. The fact that we do it, eating without thinking about it, even when it's popcorn, and even if it's 2 weeks old. And the fact that, healthy eating is not a knowing problem, so you can read all you want about nutrition. Maybe it will not change the fact that you will enjoy an hamburger, right? I also really like that part about...
What was it, 19 milliliters to 190 milliliters?
That was the normal size, right? The fact that we need to talk about pleasure. I really enjoy that part. It's better to think that it's tasty than healthy, right? So like that bit as well, right? We are somewhat afraid of anything that is new, right?
In the panel with Richard, talking about new products,
Yeah, absolutely. And people are avoiding advertising quite actively, muting the advertising.
Fast forwarding on YouTube, all of that,
right? Absolutely. About that last station, you want to map all the risk, and you want to identify the risk before they happen, right? Yeah. And I really like that last part about adding life to the days, and I really hope that I will be able to skateboard even when I'm 80 or 90. Maybe that will happen. What do you think?
I don't know. I don't know how your skateboarding is now.
Probably not great, but yeah. And also that part about the fact that there is this gap between the one we want to be and the one we really are, and maybe that one is a bit autobiographic.
Yeah. And I was thinking between the FMCG panel, the Pierre Chandon panel and the conversation with Ismaël now, both of them were talking about information isn't enough, right? We can have all the information about eating healthy. We can have all the information about being healthy, taking care of our health, but it's just not enough. We need to motivate behaviors.
Yeah, maybe we want to sell healthy food like fast food, like it's cheap, tasty, and convenient. Eat carrots.
Eat a carrot. The ultimate fast food. Thanks, Adrien.
Thank you.
So we are halfway through day one. I think I'm seeing already some of our colleagues and clients in Australia and Asia are starting to drop off. We say goodnight to you. But we definitely still see a lot of you online from the Mideast, from Africa, from here in Europe. And soon when we come back from lunch, I'll be sending out some messages on Teams to wake up our New York and Santiago teams to get them online. So thank you so much for joining us for day one, first half. We're going to take an hour break now. Edrin needs to rest his hands. I need to rest my voice. Everybody here needs to get a little bit of lunch. We'll see you back here at 2 p.m. European time. That's 1 p.m. for my team in London. And we'll see you back in an hour. Back to day one of the Human Advantage. We're staying on the theme of behavioral science. And after that fascinating conversation with Ismaël about his startup ZOＩ, we're also staying on the topic of healthcare, but this time moving to a round table with some clients and experts from major international pharmaceutical companies. So we're honored to welcome Dana Vigier, CEO of Alexion, which is part of the AstraZeneca group, Antoine Ferrere, who you saw this morning, Global Head of Behavioral and Data Science, Ethics, Risk and Compliance at Novartis, and Jean-Christophe Barland, who is now the Biotech Advisor and Investor, but also a former VP of Lead to Market at Bristol Myers Squibb.
So thanks, Ted. And this roundtable will be moderated by my close friend, Beltrande Bakoula, who is VP for France at BVA Nudge Consulting in charge of public policy and healthcare. And remember, you can ask any question and there will be a Q&A session at the end of this roundtable. So please, if you have any question, use the chat. Thanks.
Over to you, Beltrande.
Thank you, Ted and Eric. I'm really happy to be here with you this afternoon to moderate this roundtable with three fantastic speakers. I have with me Antoine on live on the studio, but also online we have Dana, who is at Copenhagen, if I'm right, and Jean-Christophe, who is at New York at the moment. So thank you to the three of you for being with us today. Maybe before to start this conversation and to wake up the audience after lunchtime, at least in France, I propose to start with a quiz. So the question is, it may be more for the French audience, but maybe other people will have an idea. In France, how many cancers each year result from exposure to preventable risk factors linked to our lifestyles and behaviors? Is that 10%, 40%, or 70%? What do you think, people? And you?
Well, I would say 70%.
70, okay. Dana, Jean-Christophe, do you have an idea?
Yeah, I will go with 40.
40, okay. And Dana?
40, as I said.
Yeah, 40. Yeah, but you're right. Jean-Christophe, Dana, you're wrong, Antoine.
That's not a good start.
But, yeah. Because according to the French National Cancer Institute, 40% of detected cancer each year could be prevented through individual behavioral change. And that's huge, but at the same time, it is quite good news because we are here to talk about behavioral change. It is the subject of the day. So, after that, maybe one question for all of you guys. How did you discover behavioral sciences, and do you think, in fact, it is useful for health challenges? Antoine, would you like?
I'm here, so I'm going to start. Thanks, first of all, really glad to be here, and thanks for the repeated invitation. I appreciate it. So, I mean, I guess my story about how I came across behavioral science is not too dissimilar to a lot of people that came on the late. So, I'm not a behavioral scientist by trade. Actually, the first book that I picked up, if I remember correctly, it was 2008. That was from Malcolm Gladwell, called The Tipping Point.
Yeah.
I don't know if you remember that book.
I remember, yeah.
A lot of social psychology, small incremental change can lead to big differences. And I was really right away interested. And of course, that led into the classic, reading Kahneman, like a lot of us here. And then I launched myself into behavioral science,
Okay. And what do you think about using behavioral sciences for health.
Well, I think it's useful, otherwise there'll be a very short panel.
Yeah.
So, I mean, look, and then, I can talk about healthcare, but also in particular about the pharma industry.
Yeah.
And then there's many ways and there's many approaches, and a lot of them have been covered about how using behavioral science is useful. But if you take a step back, really, when we're developing the treatment, when we are testing the safety and the efficacy of the treatment, we're in the business of using, biomedical, clinical science, medicine, biology. But then, of course, once those are developed and safe and working, and we want to put them into the hands of the patients who need it, then we're into a different kind of problem. We're into a decision and behavioral problem. And so the kind of point there is to say, well, let's leverage, as the pharma industry and the healthcare industry, social science as much as we're leveraging clinical and medical science. And that's for the highest level perspective.
Yeah, that's really interesting. I guess, Dana, do you have something to add for you? What do you think about using health?
I really would like to say that I have discovered it during my medical studies, right?
Yeah.
Because that's where it should have been, but it wasn't. And I actually still don't think it's a regular topic of study for future doctors either, anywhere in the world. If there is, I'm happy to hear about that. And I'll come back to that because I think this is truly the place where it should be studied. Now, the truth is I have discovered it during my INSEAD training, executive training, and Daniel Kahneman became actually one of my absolute personal gurus there. And that is precisely because I realized at that time, both as a physician and then as a business executive in pharma, that we are actually addressing healthcare issues the wrong way, in a way, acting if, patients on one side and doctors on the other, which is more important, would be purely rational system 2 thinkers, when in most cases, actually, system 1 and cognitive bias need to be addressed first and foremost, if we want then the individual's logical and scientific brain to open up. So my last words here would be really to say that I think that in a world where basically ChatGPT and alikes are getting better than doctors at diagnosis, I think that the behavioral ability for doctors to actually address their patients and nudge them for good is going to be one of the biggest added values. So I think that has a lot of value.
Yeah, I totally agree. Thank you. And you, Jean-Christophe, what do you think? Do you agree with what Dana said?
100%. In my case, I'm a curious mind and I'm a avid reader. So I came to behavioral science via my interest in psychology. So I was also very influenced by Daniel Kahneman. I also read Malcolm Gladwell, Daniel Pink. I have a personal soft spot for Dan Ariely and some of the really interesting nuggets that I collected from special findings, like I would describe this as the IKEA effect. But for me, it had also practical use. I am a leader who is really interested in transforming organization. So I used the behavioral sciences to mobilize and galvanize people and led them to take specific directions. And that would be the example I would like to develop at some stage to showcase how it could be done.
Sure, but maybe one question for Dana to start. You talked about physicians, and could you tell us, is that easy to change physicians' prescribing habits?
Good question. Question of a lifetime for half of the industry, right? Now, let me break this down in a few pieces. One piece is physicians are just as human as all of us are. Yeah, surprise. Two, why change? Because it's sort of saying, is it easy to change? Yeah, but the true question is, why change? And then the third would be, of course, define easy. Yeah, right. Okay. So if we were to address first the why change piece, I think it is critically important to be crystal clear on the fact that change, when it comes to medical interventions, be them drugs or different types of surgeries or medical or whatever that is, must be for good. And then what good means for patients as cohorts and groups is defined by evidence-based, very solid scientific data, reviewed by peers, approved by regulators. So you only want to promote change if change has proven significantly better for some patients at least. And this is all a system 2 approach, right? The sort of logical, scientific, systematic system. And this is probably what I believe we're really good at in pharma. It's sharing the scientific data. Now, the problem starts from this point onwards with the other element, which is the doctor is a human being. So most of the time, what you realize is that a doctor has perfectly heard and understood the scientific data and the clinical benefit for patients, fully validated by regulators and so on. Yet, many, many times, his or her prescribing decisions hardly change. And this is truly because, again, they're humans. Their decision-making is as much subject to cognitive bias as anybody else's. And you know what? This is something that I struggle most to sort of discuss with my teams there, because there is this aura of a super pure scientific brain. So what pharma usually does at the point where they see that the prescribing is not changing when it should be for good, really, is to creatively try and find new ways or opportunities to rediscuss and discuss again the scientific data, because maybe the doctor did not fully get it. Does this prove easy? No, it's not easy at all. And basically, after some experience, you realize that this goes against the status quo bias. So the status quo bias that anybody has is to go for the default option, right? Risk averse, familiar. So, I think that, we have had some examples, but there is maybe a couple of, at least one very pragmatic example which comes to my mind, where we sort of managed to sort of change this approach using behavioral sciences. Yeah. But maybe the others.
Do you want to react, Antoine?
No, of course. And Diana, what you said is really, really fascinating. I think there's, as a preamble, because I want to react to what she said first. I think in a way, maybe talking about the pharma industry or love for that medical science and this fact and the hard-earned evidence we generated to prove the efficacy of that treatment and the millions of dollars was invested in clinical trials, all that sometimes prevent us to letting go of that and understanding that there's something else than medical science that exists and social science that we have to embrace. And maybe that information that we have that was really hard-earned, it's not going to be enough to help us shift the behaviors of the stakeholders around us. I think in terms of areas where we could benefit from social and behavioral science, for me, one area is the whole field, and that is transforming in the pharma industry of like the whole medical affairs field, where we more and more, the old model is we have clinical trials that generates data, we launch our medication, and then we'll get it approved, we launch it, and then try to gather some data to help us understand whether it works in practice. Today, and more the regulators in different countries is coming and say, it's nice, you're running your vanilla, super clean clinical trials, but can you show me and demonstrate and give me the evidence that your treatment will work in the real world? And there's more and more pressure around that. And so if you ask yourself, what's the difference between the clinical trials and quote unquote the real world? Yes, the patients we select might be slightly different, comorbidities and all that, but a lot of the difference has to do not with the patient themselves, but the context in which they are and the environment. And what is the science that helps us understand pieces of that context in a systematic way? Behavioral science. So by leveraging that, we can get a better sense of, what's the evidence out there that we can manage to actually have an impact in the real world, but also going backward, influence how we run and design clinical trials to have a bit more diversity and a bit more noise maybe into that system in a way that will be generating evidence down the line. So it becomes really interesting. I think there's a tendency there.
Yeah, I totally agree with you both. And maybe just to go back to what you were saying, Dana, you said that physicians are humans just like us. They are affected by some biases. But how to make them change? Do you have any practical example, something that you could share where behavioral sciences make the difference?
You asked me to prepare that, so I thought about it, right?
Yeah.
Don't tell people.
Precisely.
We're here, right? Now, listen, it's several years ago in a different company than the one I'm today. And I'll stay sort of generic, but you perfectly understand why it can apply to pretty much a number of situations here. R&D had delivered an amazingly strong randomized double-blind study demonstrating beyond any doubt that a new drug was just as effective but significantly safer than the existing standard of care. So you would believe that, once you get that information across in terms of, logic and science, then basically things would immediately change. But there was also a slight difference in the dosing of the two drugs, as the standard of care was administered once a day, while the new drug had to be taken twice a day. And believe it or not, most doctors presented with the new, very strong scientific data were hugely enthusiastic about it. But at the end of the day, after a few months, the company noticed that actually they did not change their prescription. It was still the standard of care. And then the pharma team found, as they do normally, found new ways of sharing even more details of the scientific data in a scientific way. And doctors became even more enthusiastic, but it still did not change. And at least some of them started discussing and arguing that the reason why they're not changing is that they believe their patients prefer and would be more compliant with a once-a-day administration. So there was this blind spot around the safety of the drug, truly the safety, hundreds of deaths. And basically there was this discussion around the belief that the patient preference would be for administration. Now, this was not based on any kind of formal patient insight study, but actually it helped doctors cover the status quo bias. And basically, they truly did not realize that they were hence giving more weight to an alleged convenience than to the hard data. Now, here comes the behavioral science intervention. So instead of using, again, every minute of interaction with doctors to review again the statistical significance of the data in the clinical study, the pharma team decided to use those very precious minutes to only address, at the end of the day, what would be system one, and to present the doctors with two images. One image was of a person riding a single-wheel bicycle. Single wheel, one administration.
Yeah.
And the other one was another person riding a normal two-wheel bicycle. And there was only one text on it, which was a question. Which one arrived safer? So what I'm covering here is the difference between addressing system one first and then allowing the connection and the opening of the system two with the sort of information of scientific aspects. Did it work? It did. In less than 6 months, there was about 50% more patients treated with the new innovative drug and basically benefiting of the safer option, really. Yep. And that came through an incredibly simple sort of approach, but it took a lot of effort to accept that, yes, you need to address maybe first system one, to then discuss and open the truly important elements of the logical and scientific elements.
Yeah, that's really interesting. I think maybe it is also one of the power of behavioral science to frame the message in the right way so that people can understand and change their behavior, what is the most important.
And I'm sure this is again, this is a small example around prescribing physicians. That's a small part of basically public health. And I'm sure that there is so much to it, so much more to it, with such a bigger impact.
Yeah,
than
sure.
Just
okay, we talk about physicians, but Antoine, maybe for you. If we have to use behavioral sciences within the pharma industry, within the teams, what would you say to do what? Is that important for pharma people to be aware of behavioral science learnings?
Yes, of course.
Yeah.
Yes. And, speaking in my personal capacity, disclaimer, I think we have to do more as the pharma industry to embrace what we just discussed. I mean, there was this example that was given about here in that very case, we could frame that message in a particular way.
Yeah.
And that small change, those couple of seconds, minutes, might lead to vastly different health outcomes, right? The question then becomes, and there's many examples of that, right? We can throw many examples, whether it's public policy, private policy, how do you get people to donate their organ, how do you get people to wash their hands, how do you get people to eat better, how do you get people to vaccinate? I mean, there's tons and tons and tons and tons.
Yeah.
I think the point is slightly different, is to say, yes, we've done that, but was it sort of a new intuition we had? Was it kind of new approach that we discovered and, we kind of haphazardly moved into that and thought, oh, we got lucky there? How do we start moving away from that intuition into what's the scientific process we leverage to start accumulating this kind of evidence so that next time we think about, dosing, and then we have accumulated evidence about how do we best frame that, hopefully within our own organization, I would say even within the industry, the healthcare system. And so that needs to kind of embrace behavioral science, but going slightly beyond the nudges and the biases and the heuristics, and really understanding the value of behavioral science for what that is, which is, I don't think that. Those are byproduct of what the science brings, but I think the value is the ability we have as companies to embrace the best thing we invented to draw conclusion, the scientific method, right? So the way we apply that for clinical trials and drug discovery, let's apply that for the way we market our treatment, for the way we do outreach, for the way we engage with patients, for the way we try to hear what the patient wants. I think that's the duty we have, because our duty is not just to develop innovative treatment, it's to put that in the hands of the right patients. Right. So I think that's not a concrete example I'm giving. I think there's plenty. And I think people can talk much more eloquently about those than me. But I think that's the size of the prize. It's a big one, right?
Yeah, I totally agree. And you talked about engaging people, but maybe for you, Jean-Christophe, I'm quite sure we have to engage physicians, patients, but also we have to engage public stakeholders. And I think it is not only an issue about pharma industry, but also about public health. And I know you care a lot about that. And maybe if you want to react on this part about how to engage, motivate public stakeholders to commit in health causes and health behavior.
Yes, thank you. I totally agree what has been said before. For me, the behavioral science field is an incredibly powerful tool to understand the core of decision making. And with this comes as well the power to influence decision making. And like with all powerful technology, we should also reflect about the ethics of the use of behavioral science, because I think it's an important point. So the example I would like to share is, I would say, behavioral science for good. It's a timing example. We are in September, and it's the month of Septembre Nord in France, the month for pediatric cancer, mobilization against pediatric cancer. And this is what I would like to speak about, how we could use behavioral sciences to actually create coalitions and mobilize society against this tragedy. So my story starts in 2013. I was president of Bristol Myers Squibb in France, and we were in the process of developing the first immunotherapies. And in that context, immunotherapies in 2013, this was the new approach, and like always in the field of cancer, when you develop latest approach, you are contacted by a lot of people who are in a very dire state and are looking for basically the last shot at the target to try to find a solution. So I was approached by somebody called Frédéric Lemos. He had a son who was been diagnosed with DIPG. It's a devastating type of brain tumor at the age of 7, and he wanted to access immunotherapy. So we decided that we will take on this fight together. We managed to secure the treatment. Unfortunately, we couldn't save Noé. And we promised ourselves that actually we would never give up and pursue the fight for all the other kids. And this led on my side. Frédéric has done an amazing amount of things. If you look at the Tour Montparnasse, you probably will see the picture of his son. Every September, he actually mobilized, tried to raise funds, and very successfully actually for the fight against pediatric cancer. On my side, we at BMS created a large range of activities. We created a foundation for the research in immuno-oncology with a focus on oncopediatry. And in this venture, we came across something which is called the Grande Cause Nationale. The Grande Cause Nationale is a label given by the Prime Minister of France to raise awareness on specific important societal issue. And we decided to create a coalition to mobilize the French society for the fight against pediatric cancer. So here we use the role of social norms to use some behavioral jargon. We had several foundations, ARC, the BMS Foundation, a lot of patient associations. Imagine for Margot, Association Laurette Fugain, l'APEC, scientific societies join, some big hospital, Gustave Roussy, Oncopole Toulouse. And basically, we developed the application for this Grande Cause Nationale. And here came our dear friend Eric Singler with as CEO of BVA Nudge. I tried to rally people who had a very strong interest in this cause, and Eric did join the team. And BVA Nudge did a survey to try to understand really the system one around pediatric cancer. And what was fascinating is that actually, of course, it did mobilize people, but it was perceived as a relatively unknown disease, and its impact to around 2,500 kids per year in France, with 500 deaths, which are far too many, but it doesn't give the visibility that other type of cancer have. But if you frame it differently, and you actually share with people that is the #1 cause of deaths in children, you have a totally different answer. So we use the insights from this survey. We developed a very compelling communication plan. I spend a lot of time and with my teams at the Parliament, at the Senate. I used to joke that at the end we built the second largest political party in France because we had really a very strong support from the MP. We didn't win the 2017 cause. It was given to a different cause. It was given to the fight against violence towards women, but it's interestingly, the Grande Cause Nationale is really to raise the profile of a cause to help to shape public policy. And we lost on 2018, but in 2019, a law was passed in the French Parliament under the leadership of Nathalie Elimas and Michel Lezana, who were in the coalition. And that law is actually kind of game-changing. I think it's a unique piece of legislation in the world, actually. And that has actually really started to help the cause massively in terms of fleshage of financing for the research.
Okay,
so this
great.
is my story.
That's really interesting. That shows the power of behavioral sciences to change at a systemic level things. Because
Okay, no, let you finish.
No, I wanted to say that what is interesting in the different examples that we talked about all the ecosystem in health, but maybe not as patient, but as individual. How can we change our day-to-day behavior to exercise more, to eat healthy, and other things? Do you have any nudge to give us?
I wish I could give you the secret recipe, but I've been binging on a little petit four next door, so I don't think I'll get.
You have bad example.
A bad example, and then all the dessert. It was marvelous. So, but I'll come back to that. I'm afraid I won't have really great answer on the individual aspect, but there's something I want to say that relates to that about patients as individual. That's really important. But before that, just to come back, if I'm allowed for 20 seconds, on the ethics of behavioral science. I mean, look at my job title. I'm head of behavioral science in ethics, risk and compliance. Of course, we've thought a lot about the ethics of that, and I think what Jean-Christophe was saying is really true. It's like it's a very powerful tool. So, like with any powerful tool, the question is twofold. There's the easy kind of thing to manage and the easy answer, and then the easy question, I'd say. And then there's the hard question. The easy question when it comes to the ethics of behavioral science is, how do you use that? How do you use, do you have consent from people? Are people aware that part of an experiment? And, do you do sludge, nudge, and then, transparency? And so that's how. You got to have the right principles, but that's fairly straightforward and easy to do. You can have the little white paper, you can have your thing, you can publish commits, that's fine. The hard question is, why? If you say example, pharma industry, why do we choose to use that powerful tool? And here we got to make sure we select projects where benefit is shared across not just the industry, not just the company, but it feels fair and equal that it also benefits society and patients and doctors. And I think that is the real ethics of behavioral science. In a way, it has nothing to do with behavioral science. It has everything to do with there's these powerful things. How do we choose to use that? And I think that's really important to recognize. And then quickly on the failing to answer your other question, which I will do grandly. The thing I wanted to say, because you touched on that, is I think we have this thing on, again, in the pharma industry, and it's great. We talk about patient centricity. And as in, let's make sure we design a process, we listen to the insight, and we, everything is done around and for the patient. And that's very noble, and it's really important. I think, however, it can obfuscate the fact that what is the first thing a patient wants? Not to be one. Right? And so is that patient centricity? Is that human centricity? Right? So there's something that feels interesting. That could be a double-edged sword, right? And we talk about individuals, right? It's not, am I going to take this medication or that medication? It's more, am I going to take this medication or watch Netflix? But I think here, behavioral science, when it comes to health behavior, is clearly like a prime subject, because behavioral science is known. If you look at all the famous nudge, it's about doing things that either benefit others and is neutral for you, or doing things that benefit you in the long term and feels painful in the short term. Saving more tomorrow, paying your taxes, donating your organs. All the quintessential nudge example is about those kind of behaviors. You can take your medication to that list as well. So I said I'm not answering your question, but here you go.
Yeah, but it is really interesting. It maybe Dana or Jean-Christophe would have an answer. Do you have any advice to give us?
I have no advice for sure. I have no advice for anybody.
Do you nudge yourself?
Is really that to me.
Yeah.
Going through the experience, just what it showed us really is how important addressing and accepting to address system one through an effective nudge is for your health individually, for your public health, for your relationship with your patients, for instance, when you're a doctor. And I believe that this is one of the conversations, and as I started really, it's one of the conversations that need to happen in an era where basically we need to acknowledge the fact that the pure and the mere science and science, sharing and distribution and whatever is going to be very well done by artificial intelligence. So we need to find our own spot of added value there, in my opinion, our own as healthcare practitioner in a sort of wide sense, be it, healthcare stakeholders, let's put it this way. And that is, how do you nudge populations and individuals towards what is good for them instead of just telling them what's good for them, which actually doesn't work.
Yeah, I totally agree. Jean-Christophe, a last word?
Yes, I don't know if it's advice, it's some thoughts maybe. First is I really think that we should become lifelong students of behavioral science. There is always something to learn. There is always something to read. This is an absolutely amazing field. The second piece is stay curious. That's, I think, really interesting, because that leads to my third thought, which is hybridize yourself, connect dots. It's amazing what you can do when you have actually digested some reading, and suddenly you find a place where you can actually apply it. For example, in Japan, I was very involved with the manufacturing of cellular therapy. And as people know, it's a very tough field. And when you do that in a Japanese culture, where actually your team feel extremely guilty when things go wrong, you go into a very dark place. And Dan Ariely saved us in a way with the IKEA effect. I suddenly had the aha moment when I realized that actually being a nomad, I've built many IKEA pieces of furniture. And when you think that you get attached to a Billy bookshelf that costs $50 because you spend 6 hours building it, for me, I'm not a manual person. I suddenly realized that actually I could apply that in cellular therapy and turn lime into lemonade. And actually have a completely way of engaging our customers, making them understand that we were building the bookshelf together, and it was tough. And that created a lot of emotional value and actually completely changed the relationship. We won a customer experience award with that. So keep your chakra open, read, be curious, and connect the dots.
Okay, thank you. I think we have 2 minutes left and no specific question from the audience. So maybe one question, even if I know that we will talk about it tomorrow, but you mentioned it. Dana, you talked about AI, and I think it is something that is really interesting. How do you think we can merge AI and behavioral science to help patients to improve their health, to be more compliant, and so on? Do you have any thoughts to share, Dana or Antoine or Jean-Christophe? Because I think it is something interesting. Yeah.
I have some thoughts, but
Go ahead.
You have only 1 minute, but yeah.
Go ahead, 1 minute.
Okay, so 1 minute. I think it's the quality of the prompt engineering.
Yeah.
At the end of the day, I'm a heavy user of AI, And actually, the quality of what I've got in the last 6 months by continuously working on the prompt engineering and actually going into the understanding of the system, how you can teach the system, really has a massive impact on the quality of the answer you get. And here comes also the point raised about the ethics of the prompt engineering.
Okay, maybe really quickly, because we have 50 seconds. Yeah.
I can do it in 10.
Yeah, okay, perfect.
Teams of behavioral scientists, social scientists, and computer scientists win today because AI will be deployed alongside humans. It will influence human decision-making and behaviors. And so if you understand decision-making and behaviors as an outcome, you can design better AI systems.
Yeah, true. 10 seconds, Dana, maybe?
I would say same here in a way, meaning that AI is going to be an amazing tool, but it can be even better at actually implementing AI learning, behavioral science-based learning, just because it does not necessarily have our own individual blockages, as our brain have been sort of shaped in a certain way for a certain time. So AI plus behavioral science makes a great mix.
Yeah.
Very good.
Thank you very much for being with us. And our time is over, so we'll go to the other session. Bye-bye.
Thank you all.
Bye, thank you very much.
Bye.
Thank you, bye-bye.
Thanks so much, Beltrande, for leading that session. We're going to stay with healthcare, so stick with us. We have one more healthcare session coming up. But in the meantime, I wanted to check with Adrien. A lot of topics covered in that last one, Adrien. So, what are we looking at?
Oh, yeah. So, I was pretty struck by this statistic.
The beginning that Beltrande
So, I picture that that guy is fighting that cancer with change.
With behavior change. So 40% of cancers can be affected by individual behavior change.
Yeah, and we talk about physician prescribing habits. So she wonders, should I take it every day?
Yeah. So how can we use physicians and healthcare practitioners to be that driver of habit change and really make dosing, prescribing, etc. become more habitual and easier for people?
Even if physicians are humans, right? So indeed, there are biases too.
You can be expert and still be human. Yeah.
Indeed. And that powerful tool that behavioral science is, so you must use it for good. That's a big hammer there, right?
Yeah, Antoine was talking a bit about ethics, right? And about being patient centricity or just human centric, right? And healthcare is such a place where I think we're so sensitive to ethics, as we very well should be. But maybe behavioral science is that tool to be ethical. If we're, if we are adapting people's behavior for positive outcomes, we're doing the right thing.
It can also help to demonstrate that treatments indeed work in the real world, because sometimes, it works in the lab, but not in the real life, because as we know, context is everything, right? And people may use treatments in an unexpected way.
Yeah.
I was inspired by that last quote, be a lifelong learner, right? Mm-hmm. Be curious. Yeah. I think that was inspiring. And we talk a lot about engagement as well, engaging everyone. So, everyone running in the same direction all over the world, engaged around those important topics. Yeah. I believe that's all for me for that session.
For that session, great. And that's why we're hoping that you're here. We want everybody to stay curious. Behavioral science, I think, as you saw from these practitioners in healthcare, it's become a new way of looking at systems. It's become a new way at looking at patient behaviors. It's become a new way at looking at healthcare practitioner behaviors. And I think they even gave you a little bit of a teaser for tomorrow. As you know, day 2 is all about artificial intelligence, and you could hear Dana and Antoine and Jean-Christophe talking a little bit there with Beltrande about, that behavioral science can also be a way to humanize AI and make it effective for behavioral science. If we're building AI systems with behavioral science in mind, taking into account context, like you just said, Adrien, and thinking about real human behaviors, we hope that the AI systems will be more human, more realistic, more predictive of real behavior. Great. A little roundup. So where are we at? We've got day 1 all on a page.
Yep, absolutely, absolutely. That's packed with insight, right?
Yeah.
Yeah, there is a lot to consume. Maybe I will show you, I added this little illustration there because I think this is really what we witness.
We're diving in. This looks like some sort of brain soup.
Sorry. Yeah, a lot of insight, but I added this little illustration to sum up maybe what we learn, and really, yeah, everyone like really digging into that behavior and maybe.
Walking away with
some ideas. Yeah, I hope this is what happened at least.
Yeah. Great. Excellent.
And we have a lot, right?
Yeah. So keep in mind, everybody, these sketch notes will be sent to anyone who's registered, along with the links to watch the playback. Those of you who were here last year, you know that these arrived to your inbox. So make sure you check your emails in about 1 week. I'm looking at the team. They're going to send those links to all the recordings. You'll be able to look them up. You'll be able to reference Adrienne's sketch notes as well. Again, as that visual reminder, I know a client from last year showed me a picture of her desk where she'd printed out one of Adrienne's sketches and stuck it in her cubicle at work to remind her of a couple of concepts. As I mentioned, we are staying with the healthcare topic, a big place where we see behavioral science applied here at BVA, but also in healthcare systems, at pharmaceutical companies, etc. And it's an exciting place to see how we can align patient behaviors, healthcare practitioner behaviors to really increase more positive healthcare outcomes. So I think we are getting ready for our next session. I'm going to pull Eric back. I need you back. So we are excited for this third and our final session on healthcare today. But for those of you in the healthcare sector, we do have more healthcare coming at you tomorrow with a specific focus on AI. Our colleague Suzanne Kirkendall from our New York office is going to be leading an interesting session with Dr. Mitesh Patel. So we encourage you to come back tomorrow if healthcare is part of your experience.